Welcome to the Scoop Educational Masterclass brought to you by the National Association of Nutrition Professionals. Your host is Andrea Granson, the NANP's Educational Program Specialist. The information presented in this masterclass is for educational purposes only. Please note that holistic nutrition professionals do not diagnose, prevent, treat, cure, prescribe, manage, or heal diseases or medical conditions. They are also not licensed in any state and work with clients, not patients. This webinar, including all video, audio, slides, written materials, and related content, is the exclusive intellectual property of the National Association of Nutrition Professionals, NANP. Recording, copying, distributing, reselling, rebroadcasting, or repackaging this content in any format is strictly prohibited without prior written authorization from the NANP. Unauthorized reproduction or resale, including attempts to sell NANP-owned webinar content to the NANP or to third parties, is a direct violation of U.S. copyright law. Any company or individual engaging in this activity will be subject to legal action and financial liability, including statutory damages and recovery of legal fees. By participating in or accessing this webinar, you acknowledge and agree to these terms.
Welcome to Perimenopause and Bone Loss, what holistic nutrition professionals need to know. I'm Margie Bissinger. I'm a physical therapist and integrative health coach, and I've been working in the prevention and treatment of osteoporosis for over 30 years. In conjunction with Dr. Kim Millman, we founded the Bone Health Academy, where we educate practitioners on everything they need to know so they can effectively work with their clients to have strong, healthy bones and prevent unnecessary falls and fractures. So the good news is there is so much that you can do, and I'm really excited to share this information with you. So let's get started. Okay, so we see she has a fan, so she's going through perimenopause. So the objectives. So what you're going to learn today, you'll be able to understand the impact of perimenopause hormonal changes on bone health. You'll learn osteoporosis root causes and testing. You'll be able to identify essential nutrients for optimal bone health, understand the components of a complete evidence-based osteoporosis exercise program, and recognize the impact of stress and happiness on bone health and how to incorporate this into your clinical practice. So let's just go over what is perimenopause. So perimenopause is the transitional phase before menopause, when a woman's hormones begin to fluctuate. And these changes can affect menstrual cycles and create early menopausal symptoms and bone loss. So here are some key points. The average age at onset is around 47. The range can be between 40 to 51. Hormone levels begin to fluctuate. Menstrual cycles become irregular. Symptoms such as hot flashes and cheap sleep changes may appear. And bone loss accelerates during this transitional phase. And falling estrogen levels are the root cause of accelerated bone loss. And so often people just don't address bone loss until they're older, until they feel, I need to worry about this. But they're missing such an important piece, because this is when oftentimes it begins and we can nip it in the bud, as we'll talk about. So how does estrogen protect your bones? So first of all, it reduces the osteocyte cell death, and the osteocytes are the ones that produce the osteoblasts. It reduces the osteoblast cell death, when osteoblasts are the bone-building cells. It decreases oxidative stress, which causes inflammation, which affects bone loss. And it decreases the NF-kappa B activity. It reduces osteoclast formation and activity. And osteoclasts are the cells that break down bone. So it reduces the breaking down of bone, which is so helpful, and it helps regulate T cells. So let's go into T cells in a little more detail. So estrogen normally keeps the T cells from producing inflammatory cytokines. And when there's low estrogen, it increases the inflammatory cytokines, the TNF alpha, interleukin 1 and interleukin 6. And what these cytokines do, they increase something called rankle. And that's a signaling protein. It signals the body to make more osteoclasts, which break down bone. So more osteoclasts lead to increased bone breakdown. So you can see when we don't have the estrogen, we can start breaking down bone. And so that's why when does bone loss begin in perimenopause? So what they found, they did a study called the SWAN study, and they found that there was little to no bone loss during premenopause. But early perimenopause, there was minimal changes, but bone loss accelerated in late perimenopause. And that was defined as amenorrhea greater than 3 months, but less than 12 months. And the estrogen levels fell sharply during this stage. And the rate of bone loss in the lumbar spine was 1.8 to 2.3% per year, and the hip was 1 to 1.4% per year. So that was in this study. So overall, what they found is that the average all through menopause, the average annual rate of bone loss is about 2%, beginning 1 to 3 years before menopause and lasting for 5 to 10 years. So you could potentially lose 20% of your bone because of menopause. This is huge, and this is something we absolutely need to appreciate, and we can make a difference here. So this is just showing bone loss through life. So peak bone happens, the absolute peak bone, usually around 25 to 30. But the majority, 90% of a woman's bone she has by age 18 and men by the age of 20. So what at all ages, there is something that can be done because it's sort of like a bank. You build your bone when you're young. And then if you lose some when you're older, you have more in storage. So it's so important at every stage of life. But what we're talking about today is look what happens. Which was starting in perimenopause and then, continuing through menopause. So this is where we're going to talk about today and what can we do. So when you're asking your questions, it's really important what could be some of the risk factors for low bone density, even before we have this loss of estrogen due to perimenopause. So you want to know the age of the first period because after 16, it may suggest that they have delayed estrogen exposure. So they're already at risk. If they've had irregular or infrequent menstrual cycles, that also indicates that they may have low estrogen exposure for years. Now, this is interesting. Low dose oral contraceptives, that's less than 30 micrograms. They've done studies and that show that that can reduce peak bone density. So people who've been on the pill at this low dose can have lower bone density. So it's important to know this. And also, now they're not giving this, but this was big at one point, the Depo-Provera, that's associated with bone loss, and people have used that. And then just to know, because when you're asking about the birth control, progesterone IUDs do not significantly affect bone density. And just know that if they have these irregular cycles or amenorrhea, it can impair bone, how much bone they accrued, and their overall bone health. So it's just good to ask these questions so you have an idea of who may really be at risk for more bone density, for lower bone density. And these are just some references to what I just talked about. But there are other root causes of osteoporosis. So, when we're dealing with this person who's in perimenopause, yes, we need to deal with the estrogen and figure that out and know that they are at risk for losing bone just because of that. But there's so many other causes that the good news as holistic nutrition professionals that you deal with, and you can make a big difference. Because oftentimes what happens is that these root causes are never evaluated because a lot of people don't really understand the integrative approach. And later on in life, so now they have significant bone loss. They're in their 60s. And this is the time we're starting to work with their gut, with inflammation. So let's just go over these for a minute. environmental toxins, anything that can cause inflammation can cause the osteoclast to break down bone. Smoking, so they've been really, they've found that smoking is a root cause of bone loss. Different medications, we'll go into that in a minute. Gut dysbiosis, and that's always usually the first thing to deal with because if we're not absorbing or we have issues with their gut, it's going to significantly affect their bone health. Any kind of inflammation, stress, which we'll talk about, hormones, which we mentioned, celiac disease and gluten sensitivity, a very big risk factor in this population, micronutrient deficiency, excessive alcohol use, and autoimmune disorders. There are more, but these are very common, and this is something that we see in all ages. So let's just, before we go any further, let's just define osteoporosis. It's low bone mass, it's a deterioration of bone tissue, compromised bone strength, disruption of bone architecture, and the biggest problem is increased risk of fractures. Now, if we look at the slide here, we see the bone on the left has nice cross links. This is through a microscope. Where the bone on the right, you see the big difference? It's so much weaker and thinner and more likely to fracture. And the definition, osteoporosis means porous bones. And the statistics are so horrible. The first one I mentioned early on, half of American women over 50 will fracture a bone in their lifetime due to osteoporosis. 24% of people who have a hip fracture will die within a year due to complications. There's over 300,000 hip fractures, and a quarter of people end up in nursing homes after a hip fracture. So this is horrible. Someone's quality of life significantly changes. It's unbelievable after a fracture. So we really want to do everything we can. I mean, think about that. If you can help someone improve their bone health and so they don't have a fracture, that's just incredibly life-changing. And and this is all possible, and this is what you have the ability to do. So how is it diagnosed? The gold standard is called a DEXA, or a bone mineral density test. And what they do, and this is how they diagnose osteoporosis, they look at someone's bone density and they compare it to a 30-year-old. And it's called the T-score. And so normal is -1 and over. If osteopenia, -1 to -2.5. Those are standard deviations away from the 30-year-old. -2.5 or lower is osteoporosis. And severe osteoporosis is -2.5 or lower, and the presence of one fragility fracture. What that is, that's if you just were standing and you fell. So it wasn't like you fell down 2 flights of stairs and you had a fracture, because that really shouldn't happen. So this is just how it's defined. The problem is, I mean, the DEXA test is, we still want to do it. There's no question. It's important. But we have to know there's some limitations. So it measures bone density of the spine, hip, and wrist. But they found this is an older study in 2008, that bone density tests only predict 44% of women and 22% of men who will break a bone. So we just have to know that. And osteoarthritis, bone spurs, compression fractures, they're going to make the T-scores look better because there's more bone. So we have to understand a little bit when we're interpreting and looking at the DEXA results. But the key thing here, I think this is so important, the DEXA only measures bone density, not bone quality. And if we're looking at bone strength, if you fell and would you fracture your bone, it's a combination of both, the density plus the quality. So there are some other tests. I love the trabecular bone score. And what that does, that gives you additional clinical information on bone quality. It's software that's added to certain DEXA machines. And this is a link. If this link, sometimes they change links, but you can just write Medimaps, TBS or trabecular bone score in the browser if for any reason they've changed links. But what this does, so it's really good because it will tell you the quality of your bone, and it's just software. So if you're with someone, you can recommend, if they're getting their first DEXA, it's so good to also get this trabecular bone score. And this is becoming more and more popular. So I always tell people, if you can, to get, if it's, especially if it's the first time, get it, go somewhere where they have this trabecular bone score. And in terms of if you've already had a DEXA, you really can't compare one machine to the next. So then you decide, is it important that you get this, see how you've done, or do you want to get the trabecular bone score? So but if it's the first time, I highly recommend it. And I know recently I decided to change to machines and I got the trabecular bone score. And it's just so helpful because it gives you extra information. If for some reason your bone density is low, but the quality is good, that's very different than having, low bone density and poor quality. And there's also a test that they always do called the FRAX, and that they look at 12 personal lifestyle factors and it determines your 10-year probability of having an osteoporosis fracture. And it's good. They have this on all the DEXA machines, and really all the doctors will usually give you the FRAX test. It's a score. Just to know about, there's something called the Echo Light, which is REMS technology, and it's a radiation-free ultrasound scan. It measures bone density and quality, and this is much newer. So in terms of the reliability, it's still, to me, it's still under testing. It's not the gold standard, but we'll see what happens in years to come. There definitely are some advantages of this in terms of bone quality. And for people who have arthritis and other things, that will, you can get different measurements here that won't, which you may not be able to get on the DEXA test. So it's just something to know about. And it's still not considered the gold standard. And so, but just know this exists. I never recommend anyone only getting this. If you want to do this in addition to, great, but I still think it's important to have the DEXA. Okay, so a couple of things we need to know about bones is something called bone remodeling. So, as you know, we don't have the same bone that we're born with. Every 7 to 10 years, we develop a new skeleton. So, what happens is the osteoclasts, they create these small pits. They in the bone. And the reason for this is we want to always keep our bones new and fresh. So that's called bone resorption. And then fragments of this excavated bone collagen are released into bodily on the body's fluids. And then the osteoblasts come, deposit new collagen, and they fill in the pits. So this happens on a regular basis. And this is good because we don't want old bone. We want our bone to be fresh and healthy. But what can happen? So if someone gets a DEXA and it shows osteoporosis, what can happen? Now, I just want to say something. With perimenopause, right now, basically, they don't recommend bone density tests until it's changing. Any risk factor, but truth is, menopause is a risk factor, but any risk factor. But I think it's really good to get before people lose bone. So I think if it may not be covered by insurance, but I think it's very helpful to know a baseline, to know where we are before we start losing bone if possible. But what happens? You find out you have osteoporosis. And oh, just one thing, there's also a Z score. And what they do in the Z score on that bone density is they compare you to people your age. And so you see where you're at. But anyway, what happens with osteoporosis? So either, sometimes a person, a young person or perimenopause will get their test and they have osteoporosis, but maybe they've just never accrued enough bone density through their life. Maybe they never reached peak bone density in their 20s. So for example, someone who had digestive issues, or someone who was a couch potato and never exercised, or had a horrible diet, or was anorexic. So there's so many reasons why this person, especially if you're working with people who've had issues, there's a good chance that they may not have acquired, they may not have reached their peak bone in their 20s. So that's one. Maybe they have high bone turnover. Something's going on where the osteoclasts are breaking down bone and they're hyper aggressive, like all those things we talked about. Inflammation, certain medications, and that they're tearing down more bone than the osteoblast can make, even when they're functioning normally. Or the bone building cells are wearing out, not keeping up with the osteoclast. Or there's something called low bone turnover, where both the osteoclasts, which are tearing down bone, and the osteoblasts, which are building bone, are just not functioning up to par. The truth is, we need to know this. To me, to be effective in helping people at all ages with osteoporosis and bone loss, you need to know what is it. And I know all of you are into root causes, but it's the same thing with the bone. We need to know what exactly is going on if we're going to treat this effectively. Yes, there's a lot we can do, but but if we don't understand what may be the cause, we may be missing the boat. Okay, so there's a test called the C-terminal cross-linking telepeptides of type 1 collagen, also known as CTX. And I think this is so important because this is a bone. Now, do you need to do this on everybody? No. If their DEXA is fine and they're doing well, you'll just be able to do preventative things so that they don't lose bone during perimenopause. But if there is an issue, I think this is so important because what it does, it's a bone resorption marker. So it measures how much bone collagen's in your blood. So it measures the activity of the osteoclast, how much bone is really being broken down. The higher the level, the more bone breakdown is occurring. And the important thing, though, sometimes doctors will say, oh, it's not accurate. Well, it has to be done fasting and early in the morning, the same time for subsequent tests, because it changes during the day. So you always want it as early as possible. No supplemental biotin or collagen, even bone broth or strenuous exercise for 48 hours before the blood draw. Now, it's interesting because I work with functional doctors and they've done this for so long that they know the values. So these are values that Dr. Kim Millman, who I work with, put together. And we also did this in conjunction with Dr. Keith McCormick. And he wrote an amazing, amazing book called Great Bones. I actually have it right here. This is in my this is an amazing book. I highly recommend it. There's so many references, but if you wanted to learn more, this is just an amazing, amazing book. But anyway, so Dr. Kim Millman and Dr. Keith McCormick, so these are the values that we use, and it's been very helpful in the CTX. So just, I just gave this to you so you have this, but if it's less than 100, it's low, meaning you're just not having enough bone breakdown because we want some so we can have the fresh bone. 100 to less than 300 is considered normal. Ideally, 300 to 350. High is over 350, but you can see people having 500, 800. It's unbelievable. And we're going to go a little bit into hormones, but the good news is that when people who are losing bone when they go on estrogen, it's the bioidenticals, it's unbelievable. We see this CTX that could be so high go down. It's a wonderful marker. And then there's something called P1MP, or procollagen type 1 N-terminal propeptide. And that's the bone formation marker. So that measures bone building activity of the osteoblast and the production of collagen for the bone matrix. The higher the level, the more bone collagen fibers will be produced. And the same thing, you don't want collagen, biotin, or exercise, strenuous act for 48 hours. So this just measures the bone building cells. And again, here are the functional values. You don't want it less than 30. Normal is 30 to 50. Above 50 is considered high. But what's interesting is sometimes you're like, oh, great, it's so high. 90 or above could be a possible compression fracture because the body's building more bone to help heal that. So you just need to be aware. What we like to do is we like to look at the CTX over P1MP, and we want it to be like around 10. And if it's less than CTX over 10, the P1MP, it may not, we may not be building enough bone to keep up with bone loss. So just some information to have. Medications, people who are on glucocorticoids, the acid blockers, which so many people are on, the proton pump inhibitors, they reduce the stomach acid, significant risk factor for losing bone loss. Aromatase inhibitors. This is a big deal, actually, and you'll see this. So people who are on these because they've had cancer, it significantly reduces it increases the activity of the bone breakdown cells. So oftentimes these people really do need, because we don't want to just see for 5 years they just keep losing bone. And I'm a big person that when medication is needed, you can still use it in an integrative approach. And I think a lot of times in the integrative world, we don't realize that. But here, it can really be an adjunct. So that many people will go on something called reclass. I'm not going to go into the osteoporosis medications in this talk, but they'll go on reclass for 5 years, while they are on these aromatase inhibitors to help prevent bone loss. Anyway, and then they'll need to do everything else that we're going to talk about. And then there's some other thing, androgen deprivation therapy and antidepressants, where a lot of times people are on these and don't realize they can affect bone. Anything causing inflammation is going to increase the cells, the osteoclast, and break down bones. So it's not one thing. The bones are just part of everything else like we deal with. And so we need to look into the root causes of inflammation. So a couple things just in the regular blood work that you can look at is homocysteine, which is the amino acid that can make your bones stiff, fragile, and more prone to fracture. It's also a marker of B vitamin status. So any levels higher than 8 can contribute to inflammation, but they've done studies showing that levels higher than 15 have been correlated with a reduction in bone density and increase in fracture risk. High sensitivity C-reactive protein. It's a marker of systemic inflammation that affects bone turnover. So if there's too high, it can indicate there's too much interleukin 6, which is a pro-inflammatory cytokine, which will stimulate the osteoclast and again link to higher risk of osteoporosis. So we want it to be optimally below 1 milligram per liter, but if it's above 1.3, that can indicate a higher inflammatory burden and can be affecting bone health. So these are just things that we can look at in the blood work. In terms of the comprehensive metabolic panel, which has 14 different substances, and we see this in terms of the body's chemical balance and metabolism, but there's just two that I want to mention because I think you can pick things up that will completely change someone's life, and that's often missed. So let's start with serum calcium. Now, for some reason, they just have one, when you're looking at the lab work, there's just one value, one range, but it doesn't go through. Well, if you're over 40, it should, it doesn't say that. So here's the thing. I was so lucky. I've had 4 summits, but I've been able to interview Dr. Diva Boone, who's a parathyroid surgeon, and she's taught me so much. But the range is often too large and parathyroid tumors are missed. So during 4 summits, each summit, ready for this? 20 people at least, now that's just people I got notes from, found out they had a parathyroid tumor because they checked their own blood work. So this is what I learned from Diva Boone. If you're over 40, your number should be in the mid to high 9s. That's it. If it's over 10, you should be evaluated for parathyroid disease. And also low values should be looked at too. But the thing is that, what doctors do, they're like, oh, let's wait and watch. But you're losing bone. If the parathyroid, if there's a tumor, it's just taking too much bone because it doesn't have the right signals. So there's a great app. You can just go to southwestparathyroid.com/app and it has a calculator too, where you put in the value and the PTH level. And it's really wonderful. And also Dr. Diva Boone is someone who can truly help you. But they have this, you just plug it in and it will help. And my husband's an OBGYN. And because he listened to the summit, he's picked up people in their 40s they had other symptoms too, but they could be tired, they could be fatigued, there's other symptoms that just mimic menopause or just mimic life. So it can be missed. So this is something that you look at their values. If it's over 10, it can also be that they're having too many calcium supplements too. So you could also check that out as well, or too much vitamin D. But there's ways with the parathyroid, and it's something that needs to be evaluated if it's over 10. Okay, this is critical, and I think this is a very important area for all of you. Blood sugar and perimenopause. So, declining estrogen during perimenopause reduces insulin sensitivity, so it can elevate your blood glucose. Elevated blood glucose increases inflammation and stimulates the osteoclast to break down bone. A lot of people think, oh, and a lot of doctors are like, oh, I'm not going to worry about pre-diabetes. Let's just wait till they have diabetes and then we'll treat it. Well, as you know, there's so much we can do for blood sugar. But this was really interesting. In a study, midlife women with pre-diabetes before or during menopause transition have higher long-term fracture risk. So this pre-diabetes, which they use the hemoglobin A1C of a 5.7 to 6.4, which many doctors won't even bother. Oh, 5.7, no big deal, was associated with a 24% higher fracture risk. This is huge. Type 1 and type 2 diabetes are associated with reduced bone quality and increased fracture risk. So the recommendation here is that the patients get fasting glucose, hemoglobin A1C, and fasting insulin, because sometimes things are missed, and the fasting insulin is very helpful. I've seen numerous times where glucose and hemoglobin A1C was okay, but their fasting insulin wasn't. So the combination of the three really helps. And then if you find this, there's so much that can be done to help people with blood sugar regulation. I'm a huge, huge fan of wearing the continuous glucose monitor so that people get feedback on what food. But these are things that you work with and are so effective. And it can, I think we don't think about it in the context of bone loss, but it's very important. And these are just some values. I'm not going to go through them, but you have this in terms of what you want to look at for numbers. Okay, gluten. This is huge. When I did my summits, I've had 60 practitioners. Almost everyone mentions gluten as a root cause. I see this all the time because we know there's intestinal damage, so it can be malabsorption. Leaky gut can trigger inflammation leading to bone loss. When the gluten comes in, the body attacks. So it can be an autoimmune attack directly on bone tissue, leading to bone loss, or just the immune system. When the immune system gets activated, it can also, I mean, they even have now a term, osteoimmunology, because it's a correlation between the immune system and bone tissue. And then there are various tests to check for gluten antibodies and wheat sensitivities. My absolute favorite is the wheat zoomer. But the key is oftentimes what will typically happen for someone who has osteoporosis, or if, I just think there's so many people in all ages. So if someone's young, someone's in perimenopause and they have gluten issues, you need to pick this up so they can deal with it, because otherwise it's just going to compound everything and they're going to lose bone. And that's typically, you do see bone loss at a very young age. Celiac, everybody knows about. And that's the issue, that every doctor will evaluate for celiac, but they will not evaluate for anything else. And that's where we come in. We need to do all these other tests. And, you can also do an elimination diet to see what's going on. And usually it's not just, I mean, that's the problem with bones. It's not like eczema. It's not like digestive issues where oh yes, I have constipation, I have this. Sometimes it's silent. Typically there's other things, but people don't correlate it. Like typically they'll have like an eczema, or maybe they'll have digestive issues, but oftentimes they don't, or they could have a cough. I mean, there's so many, with gluten, there's so many other things that, but the bone itself, you're not going to know. That's the thing. It's a little different. So, what other things can we do? Optimizing digestion is so important. And this is something I know all of you do. Always the first thing I do is have people breathe before they eat, because so often, they're in fight or flight and they're not digesting their food, they're not getting their enzymes. So I've just found that's the first thing when anybody comes in. I've always, okay, let's just, learn how to do some deep breathing and just take some deep breaths before you eat. So powerful and so simple. But low stomach acid's a big deal. And I think because there are nutrients that require ample stomach acid that are important for the bones: protein, calcium, magnesium, B12, iron. So we really want to make sure that the person has adequate stomach acid. And I know that that's something that you work with, but it's something that can affect. Anyway, in terms of all the bone healthy nutrients, there's so many. I'm just going to, basically, but I'm just going to go over the absolutely most important ones. But all of these are important, just like everything. We want a good diet, we want the rainbow, all the things that you teach are also equally important for our bone. And I am a big believer in micronutrient testing, test, don't guess. And so oftentimes I will have people tested so that they can figure out what they're working on, as well as food sensitivities too. Okay, but a couple of things that I think is really important and very prevalent, sugar, because sugar depletes B vitamins, copper, calcium. It reduces absorption of the calcium, magnesium, protein. And we talked about elevated blood glucose. So this is something that I think is universal. A lot of these things are universal, but they will significantly help our bones. All right, let's talk about calcium because what I see is people are on too much calcium. They go to the doctor, and the recommendation from the Institute of Medicine is anyone over 50 is 1,200 milligrams a day. But that's changed. That really has changed, and not everybody feels that's the right recommendation. And just so let's see here for a second. I agree. I like the 800 to 1,000. And there was a study done, and it was a meta-analysis. So they had 13 double-blind, placebo-controlled, randomized controlled trials. So there were 28,935 participants and 14,243 controls. So that was it was good. They combined all these trials, and they found that calcium supplements increased the risk of cardiovascular disease and coronary heart disease, especially in healthy, this is more in postmenopausal women, but 15%. And they found dietary calcium of 700 to 1,000 or supplemental of over 1,000 increased the risk of cardiovascular disease and coronary heart. They did not look at taking magnesium or taking cofactors, taking vitamin K too. They did not look at other things. But still, when you see that 800 is enough to have the protection for the bones. So I think, and what I have found was that the doctors or people are, let's give more calcium. So they're taking supplemental like 1,200 and they're getting in their diet. So I think people are taking too much calcium. 99% is stored in the bones. The body takes, it's important because the body will take from your bones if not enough. And we don't want too much though, because then it can accumulate in soft tissues, joints, heart, kidney stones. And as I said, there's synergistic nutrients, the magnesium, vitamin K2. But they found that if you take 390 or less at one time, that's where you'll get the maximal absorption of the calcium. So you don't want to take more than that at one time. It's going to be not as effective. And this was just from Harvard. They even Harvard Health said how much calcium do you really need, that standard recommendations may be too high and calcium supplements could harm more than help. So that's why I think 800 to 1,000 is a better recommendation, combination food and supplements. And I always say, you know, do like a food diary for 3 days, figure out how much calcium. You can also use Chronometer. If you don't know this app, it's fantastic. So they can add up their food, they don't include high oxalate foods, and they just supplement as needed. And I'm big on food, as I'm sure all of you are. And these are just some high greens, collards, bok choy, kale that are not high oxalates. And with supplements, there are many different types that are good: dimalate, citrate, microcrystalline hydroxyapatite. But I just wanted to mention this because most people are taking calcium carbonate and it has reduced absorption and requires stomach acid. So I never recommend anyone go on calcium carbonate. I always switch them from that. Vitamin D is so, so critical, as all of you know. But the important thing here is have them have a 25 hydroxy vitamin D. And there's no right answer on how much vitamin D they should take. I always say at least 45, at least their value on the 25 hydroxy vitamin D should at least be 45. But the thing is that, a lot of integrative doctors have much higher recommendations. So it really depends. This is something that is so individualized depending on the person, and it's something that you and their practitioners that your clients are working with really need to figure out what value you're looking at. But we don't want it low, and oftentimes they're like, oh, 30 is fine, but it really is low, and we'd really like it to be at least 45. So anyway, but that's something very important that we check out their vitamin D level, and it will depend on time of year as well. All right, magnesium is another critical one. It's important for calcium absorption, helps with relaxation. It can help with constipation for certain people. That's magnesium citrate. But most people are deficient. The RDA for people over 31 is 320 women, 420 men. So that's the absolute minimum. And what we found is that at least, I mean, years ago, everybody had a 1-to-1. And I like that, 1-to-1 ratio of calcium to magnesium. And a lot of supplements do have that. But at least 50% of, if you're, at least have half the amount of calcium in magnesium, but you certainly can have a 1-to-1 ratio. And so again, there's lots of good magnesium supplements, dimalate, glycinate, citrate. L-threonate crosses the blood-brain barrier, so anybody who has any cognitive issues or brain fog, it's a good one. And then transdermal, for certain people who really aren't absorbing, transdermal can be wonderful. But just like with the calcium, magnesium oxide is one, and it's hidden. This is what kills me because I was fooled by this. Certain calciums, certain magnesium, one in particular said magnesium citrate. Great. This was a person who had issues with bowels. But yeah, when then you looked at it, it was the majority was oxide. So you have to really read these magnesiums because magnesium oxide's poorly absorbed compared to other forms. It's much cheaper. So sometimes they throw it in. So really check that out. Vitamin K2. This is essential. What K2 does, and this is in conventional medicine, calcium and vitamin D are the most important things. That's what all the doctors will put people on. Maybe magnesium, but typically not always, but never K2. And there's research on K2. I don't get it. But what K2, it activates two proteins, osteocalcin, to make sure that the calcium gets into the bones, and matrix GLA protein. And then that makes sure it doesn't go into the soft tissues. It's so important. There's two types, MK4, MK7. I'm not going to go into all this in this talk today because it's just too long. But basically, the fracture research is better with MK4. Most of it was 45 milligrams, which is a very high dose, taking 15 milligrams 3 times a day. And that there were Japanese studies showing significant fracture reduction. And this is one of the treatments in Japan. It's actually a prescription. But what they found was something called carboxylation, which is what to get it to be effective in terms of the K2 to help to help that osteocalcin work. But they found that they only needed 5 milligrams. They didn't need 45. So you can take much less. I've been now recommending 180. I recommend both, and there are certain supplements that have both. 180 micrograms of MK7 because there's research on that. Also for the heart. That's the other thing. The MK7 has been shown much more research on cardiovascular. So I think you get the best of both worlds, but I think it's important there at least on some type of K2 so that the calcium gets into the bones and not into the soft tissue. So what I've been recommending is the 180 micrograms of MK7. And this is fine, the 45, but since we found that the carboxylation of osteocalcin was okay at 5 milligrams, I've been just having people on 10 milligrams of the MK4. And as I said, there are certain supplements that contain both, but regardless, K2 is super important. And there's something called natto. That's a food in Japan and places where they had more natto, and that's MK7. They had significant reduction in osteoporosis and fractures. It's just not tasty. It's sort of slimy, and I'm still working on. Maybe if any of you let me know if you have some good natto recipes, because it is it's very healthy and it is a good source of K2. All right, just a few other things that I think are super important. So the bones, 35% is collagen matrix for flexibility, and 65% is calcium and hardness. So it's really important, this collagen matrix too, because we want the bones to be flexible. So if we fall, it doesn't crack. So what makes that? vitamin C, and sufficient protein. And more research has been done on protein. And as people get older, and this is the thing with perimenopause, protein needs increase during perimenopause due to high bone turnover and loss of lean mass. So we really need to have enough protein. And so many people, especially as they get older, are not getting enough. So the recommended intake is at least 1 to 1.2 grams per kilogram per day for most women, and 1.2 to 1.4 for active women or those aiming to maintain muscle, and up to 1.5 if people are doing, if they've had weight loss, illness, or, or they're pretty active. And the key here is the protein combined with the resistance. That gives you the strongest support of bones and muscles. All right. This is my thing because as a physical therapist, oh my goodness, I can't even tell you how important this is. Exercise and bone density in premenopausal women. They haven't studied perimenopause, but they've studied premenopausal and postmenopausal. So what they found, and this is so exciting, high impact exercises increases hip and femoral neck bone density. Okay, impact is like jumping or anything where more impact, the bones respond to the forces placed upon them. So impact plus resistance increases resistance training, that's strength training, improves lumbar spine and hip bone density. Moderate to high impact activities enhances bone strength in premenopausal cohorts. So when they've done studies and they looked at premenopausal women, same thing they found. And building, this is the key, building strong bones before perimenopause improves peak bone mass. So at all ages, when we can improve our strength and exercise, it's going to make such a difference. As I said before, the bank. The bank is good nutrition, the bank of bone we want. Good nutrition when we're younger. Exercise, because that increases the bones respond to those forces. So very important. Now this is postmenopausal women, but I have to share this because this revolutionized everything because these perimenopausal women become postmenopausal. But just to know, so this was the Lifmore trial, and they looked at 101 postmenopausal women with low bone mass for 8 months, twice a week, to 30 minutes of what's called high intensity resistance and impact training. And what they did 5 sets of 5 repetitions of greater than 85% of 1 repetition max. So it's hard versus a home-based low intensity program. So they had 2 groups. And they saw significant improvements in the bone density of the femoral neck and the lumbar spine. And they looked at this differently, and they saw that the lateral cortical thickness of the femoral neck, that's where so many fractures happen, improved, which was so exciting, and plus 6 functional measures. So but what did they do? So they took postmenopausal women, not deadlifts. So these are weighted squats. And then this is she's lifting herself up and jumping down. Now, it doesn't start like this. This is supervised. Very, very, very important. These are supervised. And it can take a really long time to learn the proper stabilization, etc. And then this is me. So I do this program, and this is overhead press. And I met the person, Belinda Back, who was the researcher. I had her on one of my summits, interviewed her. And I had asked, this is a couple of years ago, I asked, is there anyone in the United States doing this program? And she said, there's one person. And where was she? In Somerset, New Jersey, 25 minutes from where I live. So I called her. I got in the program. I've been doing it for 2 years now. I'm now doing weighted squats of 100 pounds. I'm doing 35 pounds over my head. I'm doing 95-pound deadlifts. So, it's not just me, and I'm 67. So there are people older than me, but it's supervised, it's safe. I would not tell people just go do this. But the key thing here is your people who are in perimenopause, weight training, impact. I'm a big believer in, if they can see a physical therapist, not everybody can, but it has to be done safely. Very, very, very important because they need to learn the right form. They need to learn the right breathing. These are things I teach in all of my programs. And I have a lot of physical therapists who come and teach programs, but if they can work with someone, that's the most important. I'll give you some more information on that later. Now, interesting, jumps. So now premenopausal women, they found that jumping, because it's high impact, increases bone density. So they wanted to know, what, 10, 20 jumps? What should we do? So this was a study. They took 60 women. Anyway, they had them go for 8 weeks and then 16 weeks. And one did just 10 jumps with 30 seconds in between each jump. So they did two. And basically, they found significant improvement, in the 8 weeks. And they found higher improvement in the jump 20, which was surprising. They had such increases. This was hard for me to even believe, but anyway, over time, they didn't find that there was much difference over the 60. It sort of leveled out. So, and the ground force was 3.8 to 4 times body weight. No injuries. The highest compliance was the jump 10, but they found improvement. So jumping, they can do jump rope. Jumping's a good thing. Even brief, low volume jumping can increase hip bone density with excellent safety and adherence. So that was exciting. And I think jumping is a good thing and easy to do. That's something that premenopausal women safely, you want to be in good posture, which we'll talk about in a minute. All right. So basically, for you, I think the important thing is just to understand the exercise program. It's not for you to implement it, but just make sure, if someone says, oh, I'm walking 20 miles a day, that has not been shown. Walking is good. It will help prevent falls and things, and it's a good cardiovascular, but it doesn't give enough force. Walking with a lot of people think, oh, well, I'll wear the weighted vest. Absolutely not. It's not enough force to make any difference. And I think people get tight and I think injuries happen. It's fine if they use it as part of their exercise program if they're doing squats and they want it, but absolutely it doesn't do anything. And you're going to see this craze of people, wearing weighted vests for everything. Anyway, well-rounded program. So we want the resistance training twice a week. Twice a week is ideal, at least, not on consecutive days. And it's not a lot of repetitions. I'll talk about that in a second. It's what you want. Well, I'll just tell you now. In the Liftmore, they did 5 sets of 5 repetitions, resting. We rest 2 minutes in between the 5 because it's hard. But, 8 to 10 repetitions, you can start at 15, but it's not doing 50 repetitions. It's doing, it's the forces that's causing more bone to be produced. So resistance training twice a week. You can do it 3 times a week, but at least twice a week, not on consecutive days. And that can be free weights. It can be resistance bands or the machines at the health club. Weight bearing, which is also impact. That could be running. That could be doing aerobic classes. That could be jumping. Weight bearing. That could be working on a step. And just interesting, bed rest. If you don't use it, you lose it. Studies have shown that 11 to 67 days of bed rest had almost 1% loss of bone density in the spine, lumbar spine. And then another one, 14 days of bed rest, showed increased breakdown, the CTX, and decrease in the bone. So, the osteoclasts were breaking down and the bone building cells in the P1MP. And even immobilization, when someone was immobilized, they lost 0.5 to 1% per month. So, you want to see if someone's immobilized, they should get moving as soon as they possibly can. And bed rest, if we can just move a little during that, just important to note. Okay, balance. Everybody can do balance training. And as we get older, if we don't use it, we lose it. And that comes to balance. So this is so important. They've done research that balance training reduces falls. Love, love, love Qigong, Tai Chi. It's huge. There's many other ways to do balance. Dancing, standing on one foot, moving through space. But I love Tai Chi and Qigong because you're moving through space. So that's just, balance is really critical. Posture is essential. This is a society which has horrible posture. And, the problem with poor posture, and I do a whole hour talk on posture, but when you see people rounded, their heads forward, that's going to put unnecessary forces on their back. And it's going to cause pain and even can increase fractures because, rounding out puts forces on the front of the vertebrae that's where fractures occur. So we really want to work, again, it's just if you see someone, it may be a good idea to recommend they go to physical therapy or, I always say a couple of things, spine lengthening, shoulders back and down, but just notice that if you see someone you're working with, it's just something to note, and they can work with a physical therapist and get that fixed up quickly. And aerobic, it's really good to have resistance exercise. Aerobic is really good for your cardiovascular in terms of And they have done studies showing that it is good to also, just have good cardiovascular altogether. Okay, Tai Chi and yoga and Pilates. People ask about all these all the time, and they're fine. But there was a study with yoga, and they said it increases bone density. They really didn't find that in terms of that the evidence, these were not good studies. So it's just something to note. I'm a big believer in yoga. Now, if someone has osteoporosis, we don't want to do the rounding postures. We don't want to do the extremes of motion, just comfortable motions. And we don't want to do the extremes of rotation and side bending. So, but for perimenopause, yoga is fine, but it's not the only thing. We need other things. And Pilates is good. Again, if someone actually has bone loss, we don't want the rounded postures. And there's really good information on the Bone Health and Osteoporosis Foundation site. They have some excellent information on handouts that Dr. Sherry Betts made about safe yoga, safe Pilates. But the key is they need to do more. They need to do the resistance training. And again, posture is just so important. And one thing is maintain that inward curve in your low back. You can see when you're sitting, if you're all rounded, everything falls apart. So I think it's important to help people find a physical therapist. They can go to choosept, this is the United States.com. They put in women's health or geriatric, and where it says specialist. So that's one way. Bone Fit is from Osteoporosis Canada. This is the site. You can find someone who's trained in Bone Fit. So a physical therapist will have a lot more knowledge. And you can always just call the insurance up and see what they cover and then ask, does this person specialize in osteoporosis or do you have anyone there? And Onero. So what happened when they did the Lift More study is they turned that into a program and that's the one I'm doing. They're still getting the same results and they're all over the world. So you can see that would be a great place to send someone. They're run by physical therapists or exercise physiologists. So it's safe, it's wonderful. So these are just some things I think is really important to help people do this piece because exercise is so important and it makes such a difference. And we see this when we're looking at the CTX and when people are increasing their bone density. It's amazing. So this is something I think it's important to let people know about. And stress. They've done studies in postmenopausal women, and they showed that anxiety levels were associated with bone density in both the lumbar spine and the femoral neck. High social stress was associated with greater bone loss over 6 years, a follow-up in postmenopausal women. So stress really matters. Increased cortisol causes increased activity of the osteoclast, reduced activity of the osteoblast. And so this is key. And there's so much we can do. I also teach a happiness class, but with all these things, but anything, deep breathing, there's something from heart math, quick coherence, progressive relaxation, where you tighten and relax, imagery, meditation, whatever it takes to reduce that stress is so, so important. And I think life-changing. And people don't appreciate how important this is. That's what I found working with this population. So I think anything you can do to get them even walking in nature, whatever it is, whatever works for them, but just to appreciate deep breathing, to appreciate how important this is. And my favorite thing is happiness, but they did do a study and they found that life satisfaction predicted reduced bone loss. So I do all sorts of things to help people improve their happiness. And, there's so many different things you can do. But I think to start with, to not have people be a victor in life and not a victim. So instead of focusing on what's wrong, focus on solutions. Like, okay, yeah, maybe I have bone loss, but I'm going to do exercise. I'm going to eat well, focus on solutions and also looking at what's good in the world. What you focus on grows. So when they can focus on more positive things, it really is life-changing. All right, so let's just review. So to optimize bone health, what you can do, I did not talk about the hormones. I'm a huge believer, I just have to say, huge, huge, huge believer on hormone replacement therapy and bioidentical hormones. However, that is a whole entire talk, but that's critical. I think we absolutely need to make sure if that's you who are testing, and as I said, I would have liked to have talked about that, but that would be a whole hour on all the testing and how to interpret what to do. But I think that's an area, if you have if you specialize in that, great. If not, then make sure they see someone, but let them know how important it is and how if we can get them on the hormones as early as they're starting to get changes, everything's going to change. It's going to prevent bone loss. And the studies that they used for all these years and took everybody off of hormones they weren't valid. It's so sad that a whole generation, this is my generation, was never put on because of all the dangers, and now they've retracted all that because that's not true. And so it's something that you can look more into. But for perimenopause, we can prevent bone loss. It's amazing how much it can help, and it can help all stages. But if we can get people as early as possible, and again, there's reasons where you can't use hormones, but even cortisol optimization, everything else you do, thyroid, in terms of all sorts of things with the hormones, it's going to make a huge, huge, huge difference. So I think whether it's you or whether you refer them to a practitioner, I think that's huge. But what we can do, we can look at the tests or make sure they get the right tests that we talked about for root causes and hormone status. We can support healthy hormone balance. There's lots of things we can do for that. Optimize nutrition and digestion. And we talked about this, both food and supplements. Exercise program, not that you are going to be the one, but make sure they have all the different components of an exercise program. Add tools to reduce stress and increase happiness, and just create a plan. Everybody's individualized. So these are just lots of different tools. But I think when we look at everybody you look at from now on, think about their bones, whether they're very young, whether they're very old. There's so much that can be done that's often overlooked. And I think that you are the ones that, because you're working with people, you're talking to them, you're helping them, that if this is an area to bring up. We don't want to wait. What happens, who I see, are people, they get a DEXA at 65 and they've missed this whole opportunity. So here's how you can contact me, my website, margiebissinger.com. As I said, I have this entire practitioner program I've done with Dr. Kim Millman. So if you just go to the bonehealthacademy.com, we offer it twice a year. It's a 6-month program, and people become certified integrative bone health practitioners. And I'm happy to talk to you about it if it's something you're interested in. And besides the perimenopause, the postmenopausal women, they need you. That's why we started this program, because we want to refer people to practitioners who have the basic understanding. And unfortunately, it's not out there. And so we said, all right, Dr. Millman and I said, you know what, we're going to do it. We're going to train people. And she's a physician who's been doing integrative bone health for over 15 years and has had incredible results. So we know this integrative approach works. And here's my email. Feel free to email me. I also have a podcast, Happy Bones, Happy Life, where I have all sorts of, and you can find all sorts of things on hormones. Every week we put out a podcast, and I think I'm up to 320, 330. I've been doing it for many years. So lots of interesting things. Anyway, thank you. Thank you so much. I hope this was helpful. Feel free to reach out if you have any questions. But I love doing this because I know that you are going to reach people and lives are going to be changed. And that's what's so rewarding, that this is overlooked in medicine, and yet so much can be done. And people, instead of being afraid of getting older and losing bone, they are empowered. They feel great. And they look back and say, you know what? This diagnosis was a blessing in disguise. So hope you have the opportunity, because it's so rewarding and you feel so good when you've known you've really made a big difference in their lives. So thank you so much, and feel free to reach out if you have any questions.
NANP members can earn 1 continuing education credit for participating in Scoop Masterclasses by taking the corresponding quiz, which can be found in the Learning Center of your My NANP dashboard.